Hi guys, I'm Dr. Sajjad Pathan and this is the second video of the series on Common Competencies for the Frcem Intermediate SAQ exam. So let's start with where we stopped yesterday. What is the organism implicated from the likely source of sepsis? What is the likely cause of its diarrhea? What transmission-based precaution methods are recommended? So 39-year-old guy with high-grade fever, diarrhea and discharge from surgical wound site. He was released from the hospital 5 days ago after an incision and drainage of an abscess on his thigh. He had 3 incision drainage surgeries at different sites in the last 2 years. He has no other comorbidities and he appears septic. So they have given us a person who had multiple abscesses. That means we are contemplating MRSA over here. He's admitted septic with diarrhea. What is the organism implicated from likely source of sepsis? So it could be, as we said, methicillin-resistant Staph aureus, or it could be C. diff diarrhea, antibiotic-induced diarrhea. What is the likely cause of his diarrhea? It is C. diff diarrhea or antibiotic-induced diarrhea. What transmission-based precaution? So standard precautions are standard precautions which we take: gloves, gowns, goggles, glasses. Apart from that, what other precautions will you take? This is a question they want to ask. So first thing is contact precautions. Contact precautions means you are going to be fully covered from head to toe when you enter the room. In what conditions you want to have contact precautions, they want us to know. So first thing is MRSA, second is C. diff. You need to have contact precautions. Then is droplet precaution. Droplet precaution is taken for bacteria or viruses which can be transmitted through big droplets rather than airborne. Airborne is different. Airborne is within the entire room. They are so tiny particles it can go to anyone. So airborne example is chickenpox. Droplet is your Neisseria meningitidis and mumps and rubella. So, and measles becomes airborne precaution as well. So this is what they like to ask: standard precautions and transmission-based precautions, that is contact, droplet and airborne. Normal thing is hand hygiene. You need to wash your hands before and after seeing patients. You need to do chlorhexidine rub before and after seeing patients. Surgical for surgical procedures. Okay, this is done. When is somebody deemed as MRSA negative? When you have 3 consecutive negative samples. The word consecutive is important. So you'll do it today, then after 2 months, and then after 2 months, and then when all 3 are negative, then you have eradicated MRSA from that person. Quality and safety improvement. Quality and safety improvement is very unlikely to come in the exam. However, we should know for your interview purposes, for your management portfolio, for your SJT, they can frame it up. Clinical governance is something which every trainee in the UK is involved in. Right from the start of the training, they have to be a part of it. They should know what is clinical governance. And the textbook says it's a system through which NHS organizations are accountable for improving continuously the quality of their services and safeguarding high standards of care by creating an environment in which excellence in clinical care will flourish. Now, when you go for an interview, they will ask this question: what is clinical governance? If you memorize and go, they know you have memorized it. A simple way to remember is, it is that every NHS organization is responsible to continuously monitor and maintain the highest standards of care. So it's simple. Every NHS organization are accountable and responsible to monitor and maintain the highest standards of care. An audit is you're continuously monitoring your services as compared to a national benchmark. So a quality improvement process is an audit in which we improve patient care and outcome through Review of your care against a benchmark. So there's a national guideline given, and then you are doing something, then you will see whether you are meeting those national guidelines. For example, pain control. College says severe pain, within 20 minutes of registration, pain medication should be given. Now, in my department, after a period of few months, I will sit down and see when the patient was registered and if what was his pain score. If its pain score was 7 and above, that's severe, then when was the pain medication administered and did we comply with the college requirements, and most of us are not able to do. That is why pain management becomes a priority. Medical errors. We said an emergency department is a busy place. Lot of problems can happen. Patient safety can be compromised due to multiple reasons. First reason is patient related, complicated patient, patient cannot speak the same language, or patient is demented, unable to give history, unable to provide any information. That's patient related. Provider related is you are tired, you are seeing many patients at a time, you have not taken a leave for last 2-3 weeks. So these are your related. Some personal issues are going on and you are coming to work, you are unwell, that can interfere with your judgment. Your handwriting is illegitimate, which commonly happens when you write your SAQ exams. Yes, so that is provider related. System related is too many patients, exit blocks, no beds, no resources. So in such scenarios, errors can happen. Not that we intend to do something wrong to the patient. None of us who have entered in this profession wants to do any harm to the patient. We always want to do good to our patients. But mistakes happen, errors happen. And when an error happens, we need to be taking accountability of those errors. Rather than promoting a blame culture, we have to report it without naming anybody, investigate it, and share the results across the other trusts, because if it has happened to me, it can happen to others. At the same time, there is a concept of duty of candor. You need to remember these words, duty of candor. Duty of candor means if something wrong has happened to the patient, I have a responsibility to go and first ensure that the patient is safe. After that, inform the patient and their loved ones that this mistake has happened, we are sorry for it, we are investigating it, and what we are going to do to prevent it from happening to others. That is called duty of candor. Whenever an event happens which was not required to happen, you have to fill an incident form. So they can say, there is a patient in which especially in your SJT, they will say patient is there and patient was to be transfused blood. There was another patient who needed blood transfusion. You have ordered blood for both of them, and by mistake, the blood for O has gone to A, the blood for A has gone to O. However, the moment you started, you stopped it because there was a mistake. You identified it, but you started it and you stopped it. No damage was done. What will you do first? Ensure that the patient is safe. What will you do next? You will file an incident report. You will, something we call it as datex. Why it happened. Third, you're going to tell the patient that there is a mistake which has happened. That's duty of candor. And then investigate it so that it doesn't happen again. And then share the learning across the national learning system so that it doesn't happen at other places. So see, it's a very beautiful system. And this is what it means. A patient safety incident occurs, document the incident, inform the patient, apologize, report the incident via local reporting system. That's your datex. No, this is your datex. This is reporting. And then after reporting, whatever thing comes, we share it as a national learning thing. What happens if the patient makes a complaint? if a patient makes a complaint, what will you do?
Reciprocate.
It's your responsibility to respond to them in writing or verbally within 3 days. That writing is not about anything, just an acknowledgement that thank you so much for your letter, and I'm sorry to hear that this thing has happened. We will investigate and keep you posted. And then the investigation happens. So when a patient makes a formal complaint, you need to acknowledge the complaint within 3 days. Health promotion. Health promotion can be asked in 2 ways. One is it identifies adult patient or competent patient as they are responsible for their health. So it's your duty to educate them that there are some screening programs, you can go for the screening. Secondly, encourage self-care. Catheterized patient, teach them how to change the bags, how to take care of their catheter, when they should be worried about. A patient with seizures, you need to educate them. That's when they will say, okay, what advice would you give this patient when he goes home? Like, patient is come with first fit, young chap, you've done the bloods, you've done CT scan, you've done everything, patient is normal, no neurological deficit, no red flags, and patient is ready for discharge. You have booked a yellow board or a referral to the neurology, which will be seen within a week or so. But in the interim, what is your advice to the patient?
Don't drive.
First fit, all the
First
first fit
thing.
advice.
Do not drive, and inform DVLA about your illness. Second thing, no swimming allowed. Third thing, when you use your washroom, please don't keep the door unlocked. The wordings are important. Keep the door unlocked is different from keep the door open. Yeah? So when you're going for shower or going for your toilet, you keep the door unlocked. And a responsible adult should be aware of where you are. AAA screening is normally done for any male patient above 65. Above 65, any male patient, when they come to A&E, you should do a AAA screening. More so if they come with any abdominal symptoms. Any abdominal symptom, abdominal pain, back pain, urinary problem, do a AAA screening. Okay? Breast screening is encouraged for every patient. They have to go to their GP. Any female patient, 50 to 70, they have to go to their GP and they will do the screening program. Cervical screening, females within the reproductive age group, 25 to 64. Diabetic eye screening happens annually. So you need to tell the patient that you need to schedule your eye clinic checkup. Or in history, you can ask them, you're diabetic. Okay, when was the last time you had your eye tested? Oh, I had it 3 years ago. No, you should go for your annual eye screening. I will write to your GP to arrange an annual eye screening. What is your diagnosis? Whom do you inform about his condition, and what do you do before that? If he were to be admitted in the hospital for some reason, what transmission-based precaution is recommended? 17-year-old guy is in the emergency department with history of fever and a rash for 2 days. The rash appears as in the image. He is otherwise stable and you have initiated necessary management. So, if you look at the rash properly, the rash seems to be having a papillary eruptions all over the body in different sizes, in different stages of healing. So the patient is having chickenpox, right? What is your diagnosis? Chickenpox. Which virus?
Frcem.
Varicella virus or herpes zoster. Yeah. Whom do you inform about his condition and what do you do before that?
Infection control, we can inform.
So, will you inform your local infection control? So, you need to inform the public health England. Yeah? You need to inform public health England. And what would you do before that?
Isolation. Treatment and isolation.
So I need to inform about your health condition to somebody.
Inform the patient first.
Take consent. Take consent. Yeah. So take consent of the patient, because otherwise you're breaching confidentiality. If he were to be admitted in the hospital for some reason, what transmission-based precautions? So there we studied contact, droplet, airborne, chickenpox,
Contact.
Airborne.
airborne. Chickenpox is airborne. Especially in pregnant ladies, the scenario could be like, first trimester pregnant lady is in the department saying that the school teacher has called up where she was yesterday at a school guy's birthday party, and she stayed there in the room, and then they said one guy has chickenpox. So chickenpox becomes important for how long did you stay in the room. If I was in the same room for 5 minutes, it is safe. If I was in the same room for 15 minutes and above, it is unsafe. So 15 minutes and above. So this is, you said, airborne precaution. What are your instructions to him regarding driving? Who is responsible for deciding whether he is medically fit to drive or not? If he continues to drive despite your efforts to ask him and informing his next of kin what you should do. So this is a 27-year-old guy who's come with seizure, lasted 2 minutes, absolutely stable, normal, without any deficits, bloods and imaging are normal, ready for discharge. We'll discuss this. What are instructions? Do not drive and inform DVLA, right? Who's responsible for deciding whether he's medically fit to drive or not?
The DVLA.
The DVLA is responsible. If he continues to drive despite your efforts, so first time you tell him, friend, you cannot drive, inform DVLA. He doesn't listen to you, he still drives. What will you do next? You try to get in touch with him and try to tell him, you need to stop driving. Still he doesn't listen, involve the next of kin. Can you persuade him to stop driving? Still he doesn't inform, it doesn't stop. Then you tell him, sorry, I have to inform DVLA, and then inform DVLA. Yeah. Confidentiality. Confidentiality is a legal and ethical duty. Even if the patient dies, the confidentiality remains. Consider there is a patient who died in the department. One distant relative, after several months, writes to you saying that I would like to obtain the information about his last CT scan which was done. Could it be possible? I am his granddaughter who lives in India. Could it be possible for me to obtain his CT scan? Will you give it?
No.
Who makes decision for the patient? Who makes decision for the patient? You have a patient in front of you.
Patient.
Yeah, but the patient is dead. Who makes the
No,
decision?
I'm just asking in general.
Yeah,
Patient.
In general, the patient makes the decision, right? If the patient is competent enough to make a decision, he makes a decision. If the patient is incompetent to make a decision, who makes a decision?
Doctor. Next of kin.
If it is acute emergency, you make a decision, or a person holding a legal power of attorney. Okay. If it is not an acute emergency and the legal power of attorney is not there, then the court order can be arranged. Otherwise, first thing is patient. Patient cannot make. Person holding legal power of attorney. It can be the partner, wife, brother, sister, mother, daughter, uncle, aunt, anyone. It's not the next of kin. It can be anybody. If there is no legal power of attorney, then
Doctor.
doctor. Okay? In the best interest of the patient. The best interest could be, okay, I think this patient will benefit by doing this. Or I think the patient will not benefit by doing this. I don't want the patient to suffer more. So unnecessary doing futile procedures should not be done. We make the decision. Even when the patient is competent, he cannot ask what has to be done. Like, for example, 98-year-old guy with every disease in the pathology book comes with shortness of breath, saturation of 5-6, breathing at 100, temperature of 45, heart rate of 10, blood pressure of 20/10, and now you feel if I tube him, it's not going to be useful. By the time I'm tubing him, with the drugs only he will die. With the anesthetic procedure he might die. Even if I manage to tube him, he will likely not survive. Maybe in a couple of days he will die, or he will be lifetime on ventilator. Or if I'm successful to tube him, what will happen to his blood pressure? What am I doing? Am I just prolonging the process of death rather than giving him a quality life? I think these procedures might be futile. We should not do it, because it will be more painful and we are just going to increase the sufferings rather than making it easy for the patient himself. So you make a clinical decision and you go and tell the patient, I'm not going to do this. I'm not going to do chest compressions on you if you have a cardiac arrest. I'm not going to start your nanotropes. I'm just going to give you some pain medications and make you comfortable. Patient says, no. You have to do everything. You give me chest compressions. Give me everything. What will you do?
Assess capacity first.
Patient has capacity. Full capacity patient has. What will you do?
Respect patient's decision.
You are respecting the patient decision, but patient is asking for things which are useless. What will you do?
Sign and
Patient cannot demand what they want. Patient can refuse what you are offering. Patient can refuse what you are offering. I'm not going to keep you in the intensive care unit. I'm just conservatively going to manage you and keep you in the hospital, in the ward, giving you some pain medication. Is that okay with you? No, I want chest compression. I'm not going to give you that. Patient cannot demand. However, this patient, you offered him to stay in the hospital and he says, I don't want to stay here. I don't want that treatment. And I'm having full capacity. I want to refuse it. I don't want pain medication. I don't want to be admitted in ward. I'm going home. That they have the right to do if they have capacity. Next of kin doesn't play a role. It is patient who plays the role. Patient cannot demand. If you feel the treatment will be futile, it's your clinical judgment. Patient can refuse if he has capacity. If patient doesn't have capacity, if patient has an advance directive, that can be used, or legal power of attorney can be used, or if those things are not there, you will make a decision in the best interest of your patient. This is the law. How do you assess capacity? There are 4 components. Till now, when I go to the department, my trainees, they keep on saying, I will assess the AMT. No, that's not capacity. Oh, you want me to do that whole 25? No, that's mini mental state examination. No. Capacity is independent. And a person can have capacity to do one thing and does not have a capacity to do the other. So, and capacity can be changed. So, it's not that this patient does not have capacity today, So I'm going to make the decision, I'm not going to intubate. And tomorrow, patient comes, he's fine, but tomorrow he needs intubation. And the patient says, I'm having capacity, I don't want you to intubate. So it changes. So capacity changes. And capacity is for that specific task. So you need to communicate with the patient. Patient needs to understand what you're saying or what you're offering. Patient needs to retain that information or repeat back to you. Patient needs to weigh the pros and cons of what you're offering. And patient needs to communicate his decision. These 4 things has to happen. So for an IV access, I have to go and assess capacity. After the IV access, maybe patient doesn't want a catheter. So I have to assess capacity for catheter. Okay? This is important. People do get confused. Even senior practitioners are getting confused with what to be done, what not to be done. Yeah? Confidentiality, as I said, is legal and ethical duty, and confidentiality remains even after death. So you can't give the details to that relative unless she is legal power of attorney. When can you breach confidentiality?
It's in the best interest of the patient.
So there are only 3 times where you can breach confidentiality. Only 3 times. One is when patient says, it's okay. Patient gave a consent. You can breach. Go and talk to my daughter, go and talk to my son and tell about me. You must have seen me when the cops are around and they'll say, how is the patient? And I'll just say stable or unstable. I don't say anything. If the patient is alert and fine, they want to know what's happening with the patient, I tell them, can I speak to the patient first? I go and tell the patient, is it okay if I can tell your medical condition to the officers? And if he says okay, I'll speak to them. If he says no, I'm sorry, patient did not consent. How many of us do this? This is what has to be done. So, disclosure with consent. Disclosure if required by the law in serious offences like prevention of terrorism, serious road traffic accident, NHS fraud. You can just disclose it. Some guy is taken sick leave from my hospital, but at the same time he's working in another hospital doing locum. This is fraud. He's getting salary from both places. This is NHS fraud. So you can disclose without consent. You can breach the confidentiality. Third is in public interest. Public interest means somebody is chickenpox, tell him to be isolated, stay at home till the rash goes away, but still he's roaming around. You can breach. You can inform the authorities to put him in isolation or in a place of safety. Right? Somebody is carrying a knife. You have just treated a patient who came with a cut wound. When you discharging him, when he's going out, he's carrying a knife in his pocket, and then he says, now I'm gonna go and kill 20 people. It's your responsibility to breach that confidentiality and protect those 20 people. GMC says, in addition, all intentional gun and knife crimes, serious ones, not trivial, all intentional gun and knife crimes have to be reported to the police. This is GMC says. So we have to report. Caldicott. Have you heard about Caldicott? Okay. So you should know who's Caldicott. Caldicott is a senior member of every NHS organization. Every NHS trust will have a Caldicott. This is a person who's responsible for information governance. He's responsible for all the data. So like for example, you can't access your own data. You can't access your relatives' data. It's monitored by Caldicott. So Caldicott has 6 principles. It's given in the book, you guys can read it. Yeah? 6 principles are just, you need to take minimal amount of data, you take it only when it's absolutely necessary, and keep it only for the duration when it's needed for you, and it should be strictly on need to know basis, and everybody should be aware of their responsibilities, and everybody should comply by the law. So everybody should be aware of their responsibility, everybody should comply by the law, take minimal amount of data for the justifiable amount of time, then justify the purpose why you want. Health notification is again your statutory duty. All the notifiable diseases you need to notify the authorities. Yeah, malaria, notifiable. Okay. Viral hemorrhagic fever, notifiable. Measles, mumps, rubella, notifiable. Yes. HIV,
No.
non-notifiable. DVLA. Patients are responsible to inform DVLA. You are not responsible. And DVLA is responsible to determine they are medically fit to drive or not. You are not responsible. Okay. So your steps are: you inform the patient to inform DVLA. If he is incompetent patient, then inform DVLA directly. Okay. If he is incompetent, you inform DVLA directly. Patient refuses diagnosis. Patient says, no, I don't have seizure, you are unnecessary. You tell him, if you want, I can have another practitioner to get another opinion. But till we get another opinion, no driving, please. If he's still driving, please tell him to stop. You can involve next of kin. If he's still driving, then you inform the patient that you're going to inform the DVLA, and then inform the steps. If somebody has a first fit, 6 months restriction from the day of first seizure. Somebody has TIA, 1 month. Somebody has multiple TIAs. So, in short, multiple TIAs, 3 months from the last event. Somebody has a implantable cardioverter defibrillator and it's giving shock for 6 months. Yeah. Somebody who's just got a syncope, WPW, and stable angina, they have no restrictions, they can drive. This we did yesterday, antimicrobial stewardship. Organizational approach, monitor the judicious use of antimicrobials to preserve its future effectiveness. How would you do that? By education and feedback to change prescribing practice. That's why I keep on banging my head to you guys. Which organism are you thinking? What antimicrobial you want to use? I am educating you, at the same time giving you feedback that we should do this, we should do that. Major incident can come. So, any event where the resources are less as compared to the location, number, severity of casualties is major incident. So, for example, you are just 2 doctors and suddenly 20 patients booked in. That's a major incident, right? Triage sieve is done on the scene. Yeah, triage sieve is done on the scene. Triage sort is done in the department. How I remember is, I remember triage scene rather than sieve.
Seems under the whole.
So it is done at the scene, sort is in the department. Falls in the elderly. As the population is aging, as people are becoming elderly, we are moving towards geriatric emergency departments now. Out of the 350, 400 patients you see in the department in a day, at least 200 plus are above 65. So, and as we grow old, there is a tendency that we have multiple comorbidities, there is a tendency that we have become weak and frail, there is a tendency that we are living alone, there is a tendency that we have multiple medications, there is a tendency that we have artificial joints, we need stick or walkers, walking aids, we need glasses, we can't hear properly. All these are the reasons that we fall. These are the risk factors for a fall. any elderly patient coming in the department above 65, two questions are really important in history. Apart from how did you fell, what happened before the fall, what happened during the fall, what happened after the fall. Apart from this, these two questions should be there. If anybody who comes in the department above 65, even to say you hi, tell him these two questions. Have you ever had a fall in the last few months? Second is, how do you manage your activities of daily living? Cooking, washing, cleaning, driving, shopping, accounting. These are important. We don't know it because we don't do it. It's done by the NAP team. However, it is important. That's why all 65 above they see. They go and ask only these two questions. Have you ever had a fall? And activities of daily living. Multifactorial risk assessment team is needed. There's a strong evidence for that. That apart from clinicians, we need some other people to assess them. That's why we have navigation team, we have OTPT team, we have internal medicine team, we have orthopedic team. Multifactorial risk assessment has to be done. We have social service team who goes to their home and checks. Is the heater working? Do they sleep on the ground floor or first floor? How do they walk to the first floor? Are they having extra keys? Even they check, do they have an extra key kept with the neighbor? Like that. So those things are the things which we as clinicians will not think. But that's why you need a multifactorial team. So who is Calicut Guardian? You are in the interview. I want to hire you as a trainee. You tell me, what do you mean by Calicut Guardian? It's a senior member of the NHS
Senior member who
who's
looks
responsible for information governance or data protection. What is triage C?
The triage done at the scene.
Yes, the
Junior
triage
doctor.
sort
But-
done in the emergency. This is junior doctor, this is senior clinician. What is an audit? Audit is a quality improvement project
Based on a benchmark.
to compare your, to measure your performance against a standard
Hmm.
benchmark. Yeah? Quality improvement project to measure your performance against a standard benchmark. What is antibiotic stewardship?
Judicious use of antibiotics. So that
It's an organizational approach to monitor the judicious use of antimicrobials to preserve its future effectiveness. When can you break patient confidentiality?
only 3 conditions. First one is
If the patient agrees to do
Patient
so.
consent.
Consent.
Use right words for the exam.
Patient
With patient's consent.
Second is in the what is it?
Which is the second one?
Disclosure required by law.
Law.
Disclosure in public
Public
interest.
trust.
Yeah.
Law and public.
Disclosure with consent. Disclosure required by law. Disclosure.
Public.
Public interest.
What is clinical governance?
Done by the trust.
So
It is
every NHS trust is accountable to monitor and maintain the highest standards of care, and they are accountable to the public where they serve. So our Luton Dunstable Hospital is accountable for the Luton and Dunstable population, that we have to monitor and maintain the highest standards of care. That's clinical governance, and I think we should stop here.
Thank you.